and teacher at Concordia University at St. Paul. His clinical background is in orthopedic rehab and sports medicine. Thank you very much.
Thank you. And I'm just going to show my. Okay, well, thank you very much for allowing Thermo Solutions and myself to be involved in the symposium here, the Sanibel Symposium. We certainly look forward to next year being involved in person. I hope everyone, that's probably been a common theme this week, is for the whole, everyone to get back together next year. So my short little presentation here is just a real general overview of the use of HIPEC in ovarian cancer. And I know that many of you have been certainly involved with HIPEC cases as far as with surgical oncology. The exciting thing that we've seen in the last 3, 4, 5 years is that the gynecological oncology sector has started to embrace HIPEC. And what I wanted to present you today in this short little presentation is just some of the studies that have come out recently that support that. And that's exciting news for us here at Thermo Solutions, and exciting for the treatment of cancer in ovarian too. So we all know that HIPEC, hyperthermic intraperitoneal chemotherapy, intraperitoneal, I should say, and is something that's been around for a while. And we certainly have, since about 2003, I'll show you the first study that kind of really advanced HIPEC as far as a treatment. But just a general information about HIPEC: it's a regional treatment in the peritoneal area combined with cytoreduction surgery, and it's designed really to handle late stage metastases. And generally CRS is done first, and then the HIPEC is done usually for about 60 to 90 minutes after that. And that's certainly because of limited penetration of chemotherapy through the peritoneum in the tumor. It does take a while for it to take effect. So that's why the length of time after the CRS is necessary. So HIPEC devices, they really are designed to circulate, heated, perfuse it with chemotherapy medication. And the key to that is heated perfuse it. So the temperature is about 41 to 42 degrees Celsius optimally, about 107 to 108 Fahrenheit. And that temperature is toxic to malignant tissue, but safe for normal tissue. And that's why that's why that target temperature is being used. So, and also heat also increases the permeability of chemo also. So that's an added factor in support of the temperature. One of the things that we also like to emphasize with HIPEC is that not only the temperature being at the optimal rate there, as you can see on this chart, the 4 temperature readings in this particular patient were hovering around 42 degrees Celsius, but the flow rate is very important. Here we have the flow rate at about, a little bit less than 2,500 or 2,400 milliliters per minute. And that's one of the differentiations between some protocols is that many protocols have a lower flow rate, but we found that flow rate and temperature together are really make the treatment effective. And that's that combination. Obviously, if you've been involved in the HIPEC, you've seen a closed case where they shake and bake, so to speak, of the abdomen to distribute the chemo inside the abdomen. So the initial study on CRS and HIPEC was done, and this is more in the surgical oncology realm, but it is in 2003. Vic Verwal, and a Dutch surgeon, really kind of spearheaded the effort to really popularize HIPEC with CRS. And this Dutch study was done for patients between 1998 and 2001, and it tested CRS, HIPEC versus chemotherapy alone. So that was the key component of that. It was testing the test arm was HIPEC versus the control arm was chemotherapy. So then in further, as we progressed, we found that in the last 3 to 5 years, gynecological oncology has taken some of the successes from HIPEC in the peritoneal area and applied it to the ovarian cancer. So stage 3 epithelial ovarian cancer is the commonly used conditions that are being used for HIPEC. And ovarian cancer certainly is the leading cause of death for gynecological malignancies. And many times in the way surgical oncology has gotten involved is that a lot of times those lesions will spread into the peritoneal cavity. Prior to 2018, really there were a few isolated treatment protocols involving HIPEC in the ovarian world. So the standard treatment was, prior to that, was systemic chemo and cytoreduction. So ovarian cancer and HIPEC, really the first study in 2018 to show overall survival differences was Vandriel's study et al. In 2018. And chemotherapy used was cisplatin. And the recurrence-free survival rates was encouraging. And as far as the control or the test arm with the HIPEC, it really showed an increase in overall survival rate. And this was a study of 245 patients, again in the Netherlands. So this next study was done in a Chinese study of 584, and so this time it studied CRS alone versus CRS and HIPEC. So it really went, instead of going after systemic chemotherapy, it went after CRS versus CRS plus HIPEC. And this also was measured, survival time was measured over a 3-year period, and found that HIPEC was definitely found to be effective and increased overall survival. So this was a Chinese study. One of the things, these studies coming out, what has happened is that it really have it brought the surgical oncology world together. And last year there was published 3 papers that are being called the Chicago Consensus Papers. And so this group decided to publish 3 papers on one on peritoneal surface malignancies, one on ovarian neoplasms, and the other one on colorectal. And so these papers came out, and really it was a work group that came together for consensus on treatment of these 3 conditions for cancer treatments. And one of the things that came out of it is that they mentioned these studies, at least the couple of ones that I just mentioned, being retrospective studies and the promising results that came from these retrospective studies. But the Chicago Consensus really is recommending that there needs to be further random control studies in order to get level 1 evidence. And that's really where we're at right now. Is I know there are a lot of studies going on right now that are designed to allow for prospective study in order to get that level 1 evidence. So, but the recommended HIPEC regimens there that they recommend on the screen there, cisplatin for ovarian cancer, I should say, is cisplatin with paclitaxel, and then doxorubicin with paclitaxel too, or mitomycin C. So mitomycin C is used a lot in the United States. I know that over in Europe, they in some HIPECs, they use a lot of oxaliplatin, but that's been undergone discussions too. And some of that's due to the fact that in Europe, a lot of the cases are done open, what they call the open Coliseum technique, where it's not a closed technique like most time in the U.S. where it's where that shake and bake, so to speak, is done. So they close it off and for 90 minutes. But in Europe, it's mostly open procedures. So in conclusion, really there's promising retrospective research when it comes to HIPEC for primary ovarian cancer, really in recent years. So that's promising. Prospective studies certainly are underway, and really early diagnosis is essential, just like with any cancer treatment, but the trying to prevent spread of the malignancy to peritoneal surfaces are something that is being investigated as far as being able to tackle this early when it's only in the ovarian stage. So gynecological oncologists are certainly teaming up with surgical oncology to develop regimens and protocols. And it's exciting to see the cooperation between these physician groups, and it's exciting to see the results that are coming. So we really are excited about what the next steps are. So thank you for allowing me 10 minutes, and thank you for inviting us to the conference, and we look forward to maybe meeting you guys in the next couple of days in the chat room. So thank you.
Well, thank you, Dean. We look forward to y'all do have basically you're going to do a virtual booth. Is that what day is that? Can you tell us?
I think we're both tomorrow and Friday afternoon, right?
Tomorrow and Friday. So you do have a virtual booth, so you'll be able to go into your technology. I really thank you for ending our conference today with such a positive note.